Hello everyone. In this lecture, we'll learn the management protocol of congenital toxoplasmosis. I've already discussed the natural history and clinical manifestations in the previous lecture. I highly recommend starting with that lecture first. You'll find it linked in the description below. Now, whenever we catch an acute maternal infection, our approach for treatment, it depends on the presence or potential of a fetal infection. In cases where we have positive USG soft markers, a positive PCR, or an advanced gestation of more than 18 weeks, posing a high transmission risk, our treatment strategy, it focuses on targeting fetal infection directly. In such cases, we initiate pyrimethamine and sulfadiazine therapy along with folinic acid for rescue. Else, if gestation is less than 18 weeks and there is no evidence of active fetal infection, our goal is to prevent it by giving spiramycin to the mother. So it's either spiramycin 3 grams per day in divided doses, continued until term or until a confirmed fetal infection, at which point we switch over to a combination therapy. Pyrimethamine is started with a loading dose of 100 milligrams twice daily for the first 2 days and then continued at 50 mg once daily combined with sulfadiazine 50 mg per kg per dose twice daily and folinic acid 5 to 20 mg daily as a rescue therapy. And this regimen, it is continued until the delivery of baby. If gestational age is more than 18 weeks and no soft markers are seen on ultrasound, the next step is to perform an amniocentesis. If PCR from amniotic fluid is positive, treatment is escalated to pyrimethamine and sulfadiazine folinic acid regimen. Once a baby is born, we evaluate for evidence of congenital infection through a detailed physical examination and a panel of investigations. We begin with serology. IgM and IgA, they help to detect an acute infection. IgG, if present, it must be interpreted in comparison to maternal titers. Only a significant titer should be considered as positive. Significant meaning that it is higher than IgG in the mother. If it matches the mother's levels or it is only slightly higher than the mother's level, it likely represents a passive maternal antibody transfer and not a true infection. In addition, we perform PCR testing on CSF, blood or urine to detect the toxoplasma DNA. This is followed by neuroimaging, a CT or a USG, preferably a CT scan, and a detailed ophthalmoscopic examination to rule out the classic triad. Other supportive tests like CBC, CSF analysis, BERA or ABR to assess for a subclinical infection, and a placental histopathology if it is available. If all of these evaluations are normal, or if only IgG is positive, we simply monitor the titers over time. In cases of passive IgG transfer, the titers will gradually decline and disappear over 6 to 12 months of duration. However, if IgM or IgA are positive, or there's clinical or radiological evidence of congenital toxoplasmosis despite negative acute markers, or IgG persists beyond 12 months in the infant, or there's a positive PCR from any sterile site, these findings are diagnostic of congenital toxoplasmosis and we initiate treatment with sulfadiazine and pyrimethamine along with folinic acid rescue. Pyrimethamine is initiated at a loading dose of 2 milligrams per kg per day in divided doses for the first 2 days, followed by a maintenance dose of 1 milligram per kg per day. This is continued for 2 months in asymptomatic cases and for 6 months in the symptomatic cases. Thereafter, it is tapered to 1 mg per kg per day thrice weekly, and this schedule is continued to complete a total treatment duration of 12 months. Simultaneously, we administer sulfadiazine at a dose of 50 mg per kg per dose twice daily, along with folinic acid rescue therapy at 10 mg thrice a week to prevent bone marrow suppression. In presence of severe chorioretinitis, or if CSF protein exceeds 1 gram per dl, we add prednisolone, but only after 72 hours of antitoxotherapy, and then we continue it until the resolution of these features. That concludes our discussion on congenital toxoplasmosis. We have walked through its natural history, transmission dynamics, characteristic features, diagnosis, and management. The key takeaway is that it's often an asymptomatic infection at birth with a very high potential for delayed serious complications, and hence timely diagnosis and prolonged therapy, they are crucial in preventing long-term complications. Let me know if you have any doubts or lecture topic requests. If you found this video useful, don't forget to share it with your friends and juniors. Thank you.